Assalamu alaikum. Good morning to you all, respected chairpersons. Thank you, IPDI Foundation, for giving me the opportunity to share my case here. This is a tale of a lucky driver. Not working. No, yeah. 49 years car driver and no known risk factors, no family history of heart disease. Taken to ICU when he was driving a car inside the road to pick up his own car owner from the hospital lobby. Suddenly he rushed to the garden and he was found unconscious in the car and taken to the emergency department. Then he was resuscitated there for 20 minutes CPR, then taken to ICU. And in the emergency, there was polymorphic ventricular tachycardia and ventricular fibrillation and reverted by DC cardioversion. DC shock was given and reverted to sinus rhythm. And he was taken to the ICU where I saw the patient and found troponin level is 26,000. Echo was done, and this is the ECG there. So, and whether I should take the patient to cath lab or not. Echo, this is echo. Echo is normal almost. And what could be the diagnosis then? Stroke, acute myocardial infarction with arrhythmia, resuscitated, or resuscitated cardiac death. So in the next day, serum troponin level was gone down, 11,000, patient conscious and oriented, and patient was extubated. ECG is still, this is the ECG, right? So this is scope pattern, and our diagnosis was Brugada syndrome. So if you see the ECG again, so in V1, V2, it is scope pattern, ST elevation, and T-wave inversion. So type 1 Brugada syndrome, this is our diagnosis. So that is why I did not take the patient to cath lab. And what could be the differential diagnosis by the ECG and the patient presentation? Arrhythmogenic right ventricular cardiomyopathy, early repolarization, acute pericarditis, and acute myocardial ischemia or infarctions. What next? So our plan is to put an ICD implantation, ICD, but patient was unable to, because of the financial problem, and patient was discharged on the 4th day with this ECG. Here there is no Brugada pattern. So Brugada pattern could be concealed. So patient went to another hospital where he did the angiogram and it was found normal. And after a few months, patient came to my hospital again and we did the ICD implantation for the patient, which is the right treatment for this patient. And if we look into the matters, it has already been discussed, so I'm not going to details. It has already been told the type of ECG pattern in the Brugada syndrome. So if we look into the epidemiology a bit, it is most majority affected are Asians, mostly in the Japan, Finland, also in some extent in USA. Gender, male are predominant, 9 times more the females. Impact of the testosterone on ion currents, especially potassium currents, may be the contributory factor. Age, average age is the 41 plus minus 15 years. 4% of all sudden cardiac death and 20% of the sudden death in structurally normal heart are because of the Brugada syndrome. ECG pattern is dynamic and may be concealed, and that is true in our patient as well. And meta-analysis of the 30 reports showed that 10% even rate at 2.5 years. Genetics, it is mutation in the SCN5A, that is the sodium channel. Also other genes also affected calcium channels and other genes. It is autosomal dominant inheritance, but this patient we could not find any family background of any sudden cardiac death. So this is the way out how the patients presents because of the autonomic nervous system, hypokalemia, hypothermia, bradycardia, febrile illness, all these sorts of things provokes the channels and the ECG pattern, and then PVC, polymorphic PT, that could be sustained because of the autonomic imbalance, hypokalemia, fever, or drugs. And ventricular arrhythmia, atrial fibrillation could be the pattern, and these are the provoking factors. Treatment quinidine could be tried, but treatment ICD is the choice of treatment. And this is the take-home message. Perfect ECG evaluation for cardiac patient is very vital. ECG is the gate of cardiology. Immediate and effective CPR and resuscitative measure is the cornerstone of the survival of a cardiac arrest patient. Thank you. Thank you very much, sir.